So we're continuing on in respiratory dysfunction, and we're moving to foreign body aspiration. Kids are at risk for this during that age where they put everything in their mouth. At 1 to 3 years old, they will grab whatever's there, like their big brother's Legos or marbles. The most dangerous things are things that fit perfectly into the trachea. So hot dogs, marbles, very small little things will make you cough. We've all swallowed something wrong and you cough and it hurts. But that if it's the size and shape of the trachea, then it can totally occlude, and that is life-threatening. If you see around Children's Hospital, there's a shadow box that's full of weird objects. There's nails and screws. There's crochet hooks. There's just all sorts of crazy things in there. Those are all things that they took out of children's airways. So a child swallows it, and think about it, it may not show up on x-ray. If it's not radiopaque, it may not be visible on x-ray. So whether they see it or not, based on the history, they're going to put down an endoscope, visually look in there, and then grab it with the endoscope and pull it out. And that box was all things that had been retrieved out of children's airways. The only one that died was the balloon. There was a latex balloon in there. All of the other children, who knows why they put them in their mouths or swallowed them wrong down into the trachea, but they all lived. So aspiration pneumonia, this happens when a child has feeding difficulties, swallows wrong, and usually this is going to be right upper lobe because that's the most direct route. If something runs down your trachea, that's where it's going to go to. So the goal is to prevent this. So if you lay flat with a full stomach, you're more likely to reflux, which will let you aspirate. So being elevated during and for an hour or so after feedings. Things that do slide down there easier, like oily drops and solvents. Baby powder, you want to make sure you get baby powder without talcum powder in it, because talcum can be aspirated easily. And then once it's in the lung, it causes irritation, which causes a pneumonia to develop. Acute respiratory distress syndrome. I think you'll do this in much more depth in your adult classes, but this is something you're going to see up in the ICU. This is a kid who's had normal lungs and then develops severe respiratory distress and hypoxia within 72 hours after some sort of an injury or illness. They're hard to treat. You're having to use a lot of pressure on the ventilator to get air into the lungs, to get gas exchange to happen. You're using so much pressure that you then are doing damage to the lungs, which makes you need more pressure. So it's kind of a very vicious cycle. Passive smoke. This is a big issue for kids. Everything is small. You get a little bit of swelling and it makes everything worse. So kids get ear infections, asthma, all sorts of things from the smoke exposure that wouldn't bother an adult. So we really need to encourage families where there are smokers in the house to smoke outside. They're now talking about second and third hand smoke. First hand obviously is the person smoking. Second hand is breathing in the smoke. Third hand is getting it off of items. So it's on the couch and the TV remote and all those sorts of things, and you can still get that smoke off of items. Asthma. This is what we want to really talk about now, are some of our big common disorders. So asthma. This is considered a chronic illness. It's an inflammatory disorder of the reactive portion of the lung, so the lower airways, and the symptoms you see: wheezing, breathlessness. People will complain that their chest feels tight. They'll cough, especially at night, and this is a dry cough typically. it can be triggered by a cold, so, in that case, it's going to be more moist. So the big problem is air trapping. You breathe in a lot, out a little, in more, out a little, and there comes a point where there is no more space for the lungs to expand, for air to go in. When you inhale, everything is at its biggest, and then it relaxes, so it gets a little smaller on exhalation. So that's the reason that air gets trapped, is it just is trying to get out a smaller tube. And then you have the other part is that bronchial hyperresponsiveness, so you get that bronchoconstriction. The smooth muscles around the bronchi constrict, squeezing down on the bronchi. And here's a nice picture. So there's really three parts to it. One, these muscles squeeze down. Two, the inside lumen gets swollen, and so it makes everything smaller. And then three is you have increased amount of mucus. So you can see how this can truly plug up the lungs. And then again, it's a little bit larger as you breathe in and a little smaller as you breathe out. So it's so small going out that it can't get as much air out, and that's how you get that hyperinflation. We can't classify asthma anymore using a stepwise process, and medication and treatment is based on that. So steps 1 through 5, from mild symptoms to severe symptoms. And then we also ask how frequently they're needing their medications in deciding where they fall on that. So here's the pathophysiology. I said you get that inflammation of the inside, the mucus membranes inside the lumen of the airways. You get increased secretions, and then the spasm of that smooth muscle around the bronchi. So it makes it very small and full of mucus. I like the nursing alert boxes. So this one tells us shortness of breath with decreased air movement in the chest to the point of absent breath sounds, accompanied by a sudden rise in respiratory rate, is an ominous sign indicating ventilatory failure and imminent respiratory arrest. So this kid, all of a sudden, they have reached that point where they can't breathe in anymore. The lungs are so hyperextended. So instead they start this kind of panting, little tiny bits of air movement, but very little, so little that you're not hearing air movement when you listen with your stethoscope. So hearing wheezes is much better than hearing nothing. So how do we treat asthma? We have medications for prevention, for quick relief, and then some of our other things like corticosteroids. And I think we have some more on this. So albuterol is our rapid-acting medication. It's called our rescue inhaler. Our other inhalers are for maintenance and prevention. Theophylline is a drug that we used a lot when I was first in nursing. It's not very commonly used now because the side effects are so bad. And it has one of those narrow therapeutic windows, so you get toxic easily, so you have to monitor serum levels in the blood to make sure you're to a point of being therapeutic but not toxic, and the difference between the two is not very much. So one of the things we try and do with kids is use these spacers. Really, adults should too, but kids especially, because they just can't coordinate the squeezing the medication and breathing in at the same time. It also makes it so that the medication's aerosolized in here, which lets them breathe it in with their inhalation. If they put that inhaler right against their lips and pump it, it's going to hit the back of their throat, and they're going to swallow all the medication rather than inhaling it. So we really want it a little ways out like that, and with the spacer, you don't have to do perfect timing. The mask is ideal for a kid who's either not cooperative enough or just too young to understand to put their mouth around it. But some of those have a is for you to put your lips around. This one's a mask. So if we use a mask on an infant who we can't tell, take a deep breath and hold it, we're going to put it on there for quite a few breaths. Let them breathe a few times in and out to make sure they've gotten all of the medication out of the aero chamber. If they can breathe it in deeply and hold it, that's best, but you've got to be fairly mature to understand those directions. So asthma interventions, we do have exercise-induced asthma, and those kids should be using their albuterol before they do exercise. Other kids, we tell them it's a rescue inhaler to use when they start having breathing trouble, but if it's exercise-induced, we want to prevent it. Chest physical therapy, or CPT, that's that percussion to try and break up secretions that they can then cough out better. Breathing exercises, turn, cough, deep breathe. Sensitization, a lot of these kids, they have some sort of allergy that's triggering the asthma, so that's something to consider, trying to desensitize them. Here's a kid playing with his probably continuous albuterol on, but he has a mask on, which is probably giving him continuous albuterol. So status asthmaticus, this means an asthma attack that is not responding to treatment. So at which case they will now give epinephrine sub-Q, and it's 0.1 milligrams per kilo. And that usually will help. It does make the heart race, as does the albuterol. So we also need to think, is there something else going on? Oftentimes there's some respiratory illness that's triggered it. And just because you have asthma doesn't mean you can't also have pneumonia or something else develop. So being air hungry is a very frightening feeling. We want to calm the patient, so be very reassuring. We want to know what that oxygen saturation in the blood is, so we should have them on a pulse a saturation monitor, the pulse oximetry. We're going to have kids sitting up. That's going to help that lung expansion, and that's going to be the most comfortable for them. They're usually going to want to sit up and lean onto a bedside table or something like that because they're tired. It's work to breathe, but they can get more air movement by sitting up. And anything to keep them calm and comfortable, like having the parents with them. And here we are again, letting him pick the position most comfortable. So with asthma, we want to avoid exacerbations. You can do permanent damage to the lungs over time doing repeated exacerbations. So we want to avoid that. We want to figure out what their triggers are and avoid those allergens. We want to relieve the asthmatic episode as quickly as we can, and that's going to be that rescue inhaler, albuterol, which will relieve the bronchospasm. It doesn't necessarily bring down the swelling or the excess mucus, but it will relieve that bronchospasm. And peak flow meters are a great way to see how the child is doing. They put it in the mouth, blow fast and hard, and it measures the peak flow, how much they can blow out. I've had families whose kids have asthma say they see the peak flow start to change before they see any other symptoms, so then they can add in some of those other treatments, maybe going on a steroid or adding something to prevent an exacerbation. So I think that's just about the end of time, so we'll save cystic fibrosis.